everybody. I was telling the second lady, it's always inspiring to listen to these young researchers. We've got so many of them. So we've talked about a lot today. Again, we could go on and on with all the wonderful things that we think are happening here for our veterans. But very happy to have Dr. Stecker with us.
Thank you for calling me young.
There you go. We haven't talked a lot about our affiliation with the Medical University of South Carolina here. Dr. Stecker's a VA researcher and works at our medical university. VAs could not do what we do without our affiliates. And MUSC, I've been around for a little while and have worked with a number of affiliates. I think our relationship here at this VA with the medical university is about as good as you'll find. We share staff where all of our specialists work on our side of the street part of the time, work on the MUSC side of the street part of the time, and just all kinds of research collaborations, and you'll hear about some of that today. So I'm going to turn it over to Powers.
Well, it's exciting to be down here. Charleston is one of our best hospitals in VA. Really proud of this team, proud of all of their innovation, their health care that they provide our veterans, all that they did throughout this COVID pandemic, really leading the nation. So really, really excited to be here and thank the team and everything that they're doing. But also talk about mental health. It's, as you know, ma'am, particularly important during this COVID pandemic. One of the exciting things that on the innovative side that this organization did was they stood up the first in VA tele-mental health hub. And so they really take care of veterans across the East Coast. First of its kind in VA a couple years ago, and now it's really leading the nation. VA overall has gone up on our tele-mental health side, I think about 1,100% over COVID, so really great news story for our veterans. And so I'm excited to see some of the partnerships that you have ongoing, some of the innovation. We've already heard about some of it today. But also, it's really an honor to have Mrs. Pence come to our hospital. She's been an incredible champion for our service members, our veterans, their families, caregivers, and really has done so much already for this nation and our veterans. So excited to share this wonderful organization with you and talk about some of the partnerships that we have, but really thank you for being here.
Thank you, Pam. We love going together. We've gone to a bunch of VAs together and have really seen some amazing programs. I also want to thank First Lady for being here with us today, coming along and seeing some of the things that are going on with us. I think that you're probably wondering why this is an initiative that I wanted to take on, but I became interested in art therapy as a program for children with cancer. And then when I was First Lady of Indiana, I was made aware of how art therapy is very effective with our vets, especially with PTSD. And so I started researching that, and I went over to Walter Reed and worked with Dr. Thomas DeGraba, and he started showing me some of the research they've done, showed me the MEG with music therapy and how we could see the brain healing after the therapy. And I was fascinated by this and decided this is something I wanted to champion because people don't understand art therapy and they think it's arts and crafts. And so because of that, I started meeting so many vets and started to really have a heart for our vets, especially who are experiencing TBI and PTSD. And then I had the president ask me if I would be the lead ambassador for Prevents. And I was sharing earlier that I wasn't very well informed with suicide prevention. So at the Vice President's residence, we had the whole Prevents group come, brief me, tell me about what Prevents is, tell me what you're doing, tell me how I can help. And we've been able to go out and kind of tell the story. And I know that I'm not the person at this table for sure who is the expert on helping our vets. But I do know that while I'm in this position, I can elevate this issue. And one of the main things that I want to do is get rid of the stigma and start the conversation. So You all know we just launched our REACH campaign about reaching out and talking about suicide, that's the first step. But once we start talking about it, this is where we want our men and women to come. And we're a military family, and to know that the VA is there for my son and my son-in-law is inspiring for me, because my son-in-law is deployed right now. My son actually just flew from South Carolina to Arizona today. He was training out here at, he flies for the Marine Corps, and so he did a cross-country. And anyway, I want to turn it over to you, because I think the stuff that you're working on just is like phenomenal. So the rest of the time, we want to hear from you.
Well, I hope we can have dialogue and discussion, please. I'm going to bring out my little flashcards, because I am old, not young, thank you. And even though I didn't want to have an academic presentation, I wanted it to be more casual and cozy. I'm old enough that I might need little reminders of what I'm
That's
doing
okay. I use cards. My staff is all laughing because I got a whole notebook of cards that I take with me everywhere. So.
Hi, everybody. Your staff is awesome.
Ooh, that's great. Megan, did you hear that? She just said you're awesome. Yes, and Haley. Yeah, thank you.
Oh, hi, Haley.
She's nice.
She's red.
Okay, so I really want to talk about 4 things, but again, please, I open this up. Anybody who would like to ask questions or make comments, please do. The 4 things I want to talk about are my trials that have been focused on help seeking among our veterans who need help, whether it be for PTSD or substance use or for suicide. So I want to talk about my trials. I want to talk about what it is that I do, what my intervention is, and it is focused on help-seeking behavior. I want to talk about the most prevalent barriers that veterans report about seeking help, and I want to just give some examples of some men that I've worked with. So again, please comment at any time. Hugh, I'm glad you're here. But
we're Clemson Tigers
yeah. But I kind of wish I had Mrs. Pence's.
Is this a cool mask?
Yeah, pretty cool.
Yeah, it's perfect for speaking, because I feel like every time I inhale it like sucks right in.
I know.
So excuse my. Okay, so I've been doing this since 2005, and it really started when our men and women started to come back from the wars in Iraq and Afghanistan, and they started to report some problems that they were having, and a lot of stigma, just very unlikely to come in for help. Our suicide rates started going up, a lot of reports about PTSD and trauma, and very unlikely to come in. So I proposed to NIMH a project to develop and test my intervention, and it was funded, and we got a good signal on that project that we were maybe able to improve treatment engagement with this particular intervention. We then asked for funding from NIAAA to do the same thing with individuals with alcohol use disorders. These were both pilot level trials, and again, we got signals on both. So then we went back in for the big effectiveness level trials to see if we had something. And in both trials, our results were good. We've gotten funded by VA twice to see if we could do this in primary care, to see if we could do this through the crisis line, and the answers are yes and yes. And then we had a big trial funded through the Department of Defense, which you've heard me speak about. We recruited 1,000 veterans and military members who were reporting suicidal thoughts and not at all interested in going to treatment. And so we tested whether this intervention works to get them to go to treatment. Results are pretty consistent over all trials. The individuals who get this intervention are 2 to 3 times more likely to go to treatment. They get more treatment, and they get better. They get better quicker, too. So this is good, because one thing we know about our veterans who are at risk for suicide, who are having suicidal thoughts, is if they're in treatment, they're doing better than the ones that are not in treatment. So the goal is
Get them in.
to get them in. Yeah. One card done. So what is it? What do I do? It's called CBT for treatment seeking. It is a basic 1-hour CBT session, which means it's delivered by phone, it's delivered by a psychologist, and the session has 4 different components. The first component is that it's a brief clinical interview. Essentially, what's going on for you? What symptoms are you having? How often are you having them? When do they start? How frequent? Oh, I said how often. How severe are they? And for that individual, which one is bothering them the most? Which is really important because sometimes our veterans want to come in for a certain type of issue, and they're likely to be diverted to get different treatment that providers might think is more important. For example, we have a lot of veterans who come in with some pretty substantial substance use issues. They want sleep treatment, but they'll be diverted to maybe substance use treatment. We want treated first. And if we can get them in the door to sleep treatment, that's good for us because maybe they could get a little bit of help with that and then get over to substance use. Okay, so a brief clinical interview, that's step 1. Step 2 is for all of the symptoms that they're reporting, what if they tried to do to make it better? What's worked for them and what hasn't worked? So getting a sense of what they've really done. Some of our veterans do report drinking in order to sleep or marijuana use in order to calm their anxiety or their agitation. So getting a sense of what they've done, what's worked in their perception, what hasn't worked. Sometimes some of the stuff works for a little while and then it stops working. And so just getting a sense of that history. The third step is finding out what their thoughts are about coming in for treatment. In terms of help-seeking behavior, I'm totally going off the cuff here, but there's essentially 3 different types of responses to help-seeking. People either want to come in, and we know those people, because the second they have a symptom, they're here. They're asking for help. People, or they don't want to come in. Of that group, they either don't want to come in, and there's not really a good, clear reason why. It's like when you turn 50, you have to get a colonoscopy. Some people are like, yes, I don't want colon cancer. Sign me up. Other people are like, no. Why would I do that? And if you sit them down and talk to them about that decision, whether or not to get a colonoscopy, there's nothing there to really, there's nothing concrete to talk about. It's just a why. Right? So there's those people, and then there's the other people that have a very logical reason why they're not coming. Maybe a bad experience with healthcare in the past. Maybe, I'm not thinking of another example right now, but
They don't trust the government, right?
Mm-hmm.
A lot of
Something like
times,
that, yeah.
some of our veterans just don't want to have anything to do with the VA because they didn't, appreciate their service. They have bad feelings about the military, and so they don't want to, do anything else in the federal
or
government.
vice versa. They love their job in the military and they don't want to lose their clearance.
That too.
Yeah. So some of it might be a very concrete, real reason why they're not coming in. So those are the 3 types. That was my off-the-cuff report. It's not published.
Well done.
Yeah, to your point, and I've been with VA a long time, some of it is that stigma. I had a bad experience in the VA 10 years ago, so I have not stepped foot in the VA, and we don't realize it's a much different VA today than it was 10 years
I
ago.
think we got a lot of antiquated thinking about what that might have come up in some of the interviews.
Yeah.
It's, if you go back 20 years, even 10 years ago, it's a different system at this point. So, and there's a lot of the rumor that circulates about that.
And I think it's while they're in, too. They're discouraged. It's like, oh, if I go and say I'm having these kind of thoughts, I'm not going to be able to stay in the military, or I'm not going to be able to advance. And we need to get over that as well. We need to start at the very beginning and say, we're here to help you, and it's okay to say you're not okay.
And one other thing, military members, service members, I'm a 30-year veteran myself. Military, they like to think they're strong, and they can do it themselves, and they can get well themselves. They don't need somebody else helping them. Oh, sorry.
You're jumping ahead.
Sorry about that. Go ahead.
We'll come back to that. I just yelled at a 30-year military. All right, so that was the third step. What are your thoughts about treatment? And then the 4th step is the deep dive on every one of their thoughts that they reported, which I've I've been doing this particular intervention for 15 years. It is amazing to me. When you ask them their thoughts about treatment, they come out like this. It is so fast. Boom, boom, boom. I don't have time. I don't want to be labeled crazy. I don't want a medicine. And boom, boom, boom. So then we slow that down. Let's talk about each one of your thoughts and really dig deeper. When we dig deeper, we find out that the cause of most of the reasons why people don't want to come in for treatment, veterans don't want to come in, it's some sort of discomfort. There's something there they feel they'll be uncomfortable. So we work through that. So now we're going to talk about the thoughts, card number 3. The thoughts about treatment. The most common thoughts that are reported about treatment, there are 9 that we found. I'm going to talk about the top 4. The most common thought about treatment is exactly what I've been talking about. It's kind of this vague thought about treatment, but there's nothing real there. A lot of the most commonly reported thought about treatment is, I don't want a medicine. And so as soon as you start talking to them about that, okay, if you don't want a medicine, what would you like? What do you think would help you? They're actually excited about other options, including things like art therapy. I've had people say yoga will help me, massage will help me. A lot of people will say, I want to talk to somebody one-on-one. But these thoughts are things like, I don't want group, I don't want a medicine. And those are okay. We just talk about those for a minute and then steer them more toward the treatment they think would work for them. The second most common thought is, I can handle it on my own. And that is a harder one to work through, much harder to work through. They're strong people. They're confident people for sure. And they're struggling with something that they don't necessarily know how to work through, and they want to do it on their own. A lot of our conversations with the people we work with are things like, that really is against your military training. There's nothing in military training that says do this on your own. It's all team-based, right?
Yep.
So we talk about that, and if there is something in your job you don't know, you go to an expert and you ask for some tips, you ask for some help. Maybe that's a situation here where you're just getting some tips. It doesn't have to be, you're hospitalized for 2 years and the rest of your life you're in treatment. This is something maybe you can do an 8-session brief treatment, get some tips for how to help you, and go from there. And that seems to really like them. But that's the second most common reported thought about treatment. The third most common reported thought about treatment are thoughts about the VA. The obstacles, there's this perceived perception of obstacles. It's just too hard to get in. Then you have to go through this whole process that is overwhelming to them, especially when they're in a suicidal crisis. Or they'll say things like, it's too far. They just don't understand all the services that VA actually has available to them. They don't know. And so sometimes that's a really easy one to work through because it's a relief to know we can get to you. We can make this happen. And then the fourth most common thought about treatment is my favorite and the one that I think is really important when somebody talks about it is self-stigma. So it's very hard when you're a confident individual to admit you're having a problem. It's hard enough to tell somebody else, but it's really hard to just admit it to yourself. You just want to think that it's not true. I heard a lot of people say, I knew what I was getting into when I joined the military. I was trained for this. I was ready for this. I cannot believe I'm struggling now. And so
I hear that a lot from the art therapy guys. They'll say, I'm a commander. I can't. No. This can't be happening to me.
Right.
And now they're reaching out to their guys under their command saying, go get help. I did. So they're rare though.
Yeah.
Those guys.
Yeah, I think that at least between 2005 and I don't know when, I'm not entirely sure when, something happened with PTSD where it was there was a lot of stigma about going to treatment, and then all of a sudden it was cool. Like, I have PTSD because I went to war as a badge of honor. I heard a lot of guys say I use it as a pickup line in a ball. It got cool for a little while to have symptoms of PTSD. You served, you were there, you experienced war. But somewhere along the way that seems to have gone away a little bit, and always been stigma against substance use disorders if you're in the military. Depression is not very cool, and now PTSD is starting to turn back that way. And so we still have a lot to work through in terms of stigma.
Yeah, on the VA brand, it's always a constant struggle, and I think most of the nation doesn't realize that VA. I mean, Dartmouth did a study. On average, VA is better or as good as the private sector in every sector of the United States. But we're still dealing with the 2014 access scandal, and it's a completely different VA than it was back in 2014. And we're leading the nation in mental health. We're leading the nation in so many different areas. It's really hard when one of the 9 million veterans doesn't get the health care that they deserve on time. It's national news. And so, like to, point out the bad things and not all the incredibly great things that this organization does every single day. So it's been a frustration for sure.
Yeah, and we really, we try to get that message out, but I also think it's really important when we get that message out, because you can't wait until someone is at the door to enroll in the VA. So we work really closely with our DoD partners here in Charleston and try to make sure that while they're still active duty, we start providing that information, start talking about what is available to them. Because once they're discharged, I mean, at that point, some of the things that are out there, again, the experience 10 years ago, that's already in their head. And then they're rushing. They don't know what the future is going to look like. It's that change from military discipline to what's after the military. And it's a stressful time. And really figuring out how to get that VA information to them earlier before they're discharged. That's something we've really worked hard on.
One of the things I was mentioning earlier is we have a new program called Solid Start, and I'm not sure if you're aware of it, but we'll do 3 calls that first year to all of our transitioning service members to talk to them about their, health, mentally and physically. No, this is the VDA, the Veterans Benefits, but they're working with VHA to do those calls. And it's outreach to help them understand what the benefits are in VA. Talk to them about their, well-being and whether or not they're safe and have a job. And, there's a lot of different benefits and all different sides, and it's really talking them through that. And it's been very successful so far. We just started it this past year, and it's been a great program. But I know that's one of the areas that you've been focused on is that outreach, right, and those phone calls.
Absolutely. I mean, just being available to them, to talk them through something, rather than waiting for them to catastrophic to happen, for them to get in the door. Because, we know most of our veterans who have suicidal thoughts are unlikely to seek help. There are some that come in right away, and we know those. We can capture those right away. But most of them are not coming in. Yeah. And so just having a service available, this includes the crisis line. They can call
I was going to ask you to talk about the crisis line a little bit.
Yeah, the crisis line is exceptional. They're very good. They can connect people who care if there's an imminent risk. They can help reduce the distress in the immediate people, that right at that time.
Yeah, in that moment. Yeah.
Well, so it's also the warm handoffs. Yeah. So the calls go straight to us. If we get anything in our area, it comes straight to us. I do want to go back to something that you mentioned. It was the buzzword. You said brand.
Yeah.
And I think if VA was a Fortune 500 company, we'd be doing a lot more in terms of our brand and getting that message out about human services, about the wraparound services, about all the things that we can provide to get rid of these 10-year, 15-year-old notions that people might have, and also to get that leaven of 17.
Yeah.
Because that's what Dr. Stecker, she's
really
getting
hard.
to that leaven of 17 for us, but we could actually have some help.
Nobody wants to print that, right? Nobody wants to say that VA is doing well and really providing great service. And so, we did that Choose VA campaign that we've worked with some partners to get the message out. Comcast, T-Mobile had some ads out there. But it's a constant struggle getting that message out. But we're going to continue to try and push it out for sure.
And we do a lot of that in Charleston, trying to get that
I know,
message
you guys
out.
are really good about that, Aaron.
And We went to our central office to get approval to put billboards on I-20,
Oh, great.
which shouldn't be a big deal. It was a lot to get there, but the number of veterans that say, "Hey, I saw your billboard on I-20. I see that." I'm sorry, yeah, not I-20, 26. Just they drive by that and say, "I see where you're a top facility. Provide excellent care." Give it a
Be
shot.
There was prominently in New York Times on the big billboard. Did you see that? That was pretty
Right.
cool. But yeah, it's important.
And I think part of that brand is what we've seen with COVID, and that's virtual care. Now that stigma of walking into a VA facility, even Ian and I, when we've opened some new clinics, what for the mental health check-in area, what do you call that? You don't want to be a patient walking into the mental health check-in area. So what do you call that? But now veterans don't have to walk into a building to have everybody looking to see where they're going. They can do it at home, maybe eventually do it on an iPhone. That's part of the brand, and VA does that mental health and the virtual care better than anyone. So I think that will help. That needs to be part of the branding of VA.
Are you seeing that in part of your research is getting more in to access mental health on the telehealth side?
Well, so I see that in all aspects of my work, not just with veterans, but I think this pandemic has been instrumental in that. I mean, it's going to be one of the positive outcomes of what happened, and it's going to be very good for them in terms of their mental health.
Yeah.
So, Doctor, your research is basically trying to figure out why they're not coming in.
Yeah, so in the whole piece of the whole pie of suicide, I mean, one piece of it, suicide is such a complex issue. There are so many factors involved. My work has always been focused on that one piece, which is stigma and treatment taking. Suicide, the Center of Excellence for Suicide Prevention up at the kind of Dayton VA, which is where the crisis was. Did you visit there?
Oh my gosh, I didn't visit there, but I have a call with 3 of our responders, and I mean, my staff was listening in from the had to stop. I just couldn't even speak. I was overcome. And it wasn't so much, it wasn't the tragedy of suicide that was overwhelming. It was the love and honor of those responders who wanted the opportunity to carry that vet all the way to the VA clinic and stay on the phone with them and walk them down that path together. And they were all vets who answered. And they were just like, this is the greatest honor of my life. And I just wish our vets knew that we want to come alongside our vets. We care so much about them. We owe all of our freedom to them. And it's our duty now to say, you've been through a lot. We can help you process that and lead a normal life. So I just want to thank all of you for what you're doing. I don't know what our time is like at all because I've kind of gotten swept up in this whole conversation.
Yeah, about 10 more minutes.
Okay, about 10 more minutes. But it was just what you're doing, and I know that here, if someone calls in, they come in the same day.
Absolutely.
Yeah. That's what we want them to know. We're here right now. 10 minutes from now, we'll meet you at the front door.
And they don't have to be or have a disability. They don't even have to be in our system. We'll get them in our system. And that's what we want our veterans to know is that we are here any time of day.
But you have really good response time here.
We do, and have great access and quality care. It's getting them in the door, getting them to again, don't think about what the VA may have looked like in the past, but I've talked to so many veterans that once you can get them in the door and they see the range of services that are available to them and see the quality of our providers and frankly see the other veterans that are also getting that care and can have that camaraderie with other veterans that may have been through things similar to them. It's just
they're the ones who can do it best.
So one of the things that's really exciting is the Governor's Challenge. I apologize.
Yeah.
And I know you guys as part
talk about it, it's not just the VA. It's like it's other country, other communities, these wraparound services. We can't do it alone. We need our congressional partners. We need state and local, federal. That's how we do it. And that's we realize that.
Yeah, 60% of veterans don't use VA, so you know, it's stigma aspect in the private sector as well. Scott, can you talk a little bit about what you did with the 500 police officers, local police officers, training them to understand VA?
Right, that's part. This started several years ago where we had us have to go out and train all the local police officers on recognizing PTSD signs, symptoms, but also essentially a SANE training, suicide. And it was kind of difficult because they have 3 shifts, so we had to like hit all 3 shifts. And now we've trained Tri-County area, we trained some down in our Georgia Seawalker area, and those are just the type of outreaches and partnerships you need, especially when we do welfare checks when they know us at that point in time. The other big group that we're spending more time right now is the clergy. I had the opportunity last year to go to Atlanta and do a half-day suicide prevention workshop with the head clergy of Georgia. And one of the clergy there said, if we've got to figure out that we need to partner because we can't pray. And I was like, well, we've got to figure out that if we send somebody to you that are better, will stay in touch with us. It was really breaking down those silos of the clergy and us, and we can work together. And we can send people back and forth because moral injuries are real bad, right? So matter of fact, our mental health summit that we did in the fall is coming up. So that we're doing a clergy summit. So just kind of changing the focus around a little bit on that.
It's really powerful because different things we do. There's like a faith outreach, and we have several calls that we did with clergy and interviews we did encouraging our clergy to be there. But it's one of the protective powers is having that church and that connection, that safe.
I think we're having a little bit of a hard time keeping that going, so I'm sure that you guys go out and some of the that's great.
I think the only kind of really since we have the nurse, and I bet some of the, when you did a deep dive, and that probably came up. I mean, some people were deeply rooted in church, and they go to military to do things that they kind of don't think it's the Lord, right? So then, or silos, right? You have to like this, you think it's this. It's not. It's so much more than that. We all have to expand our horizons and get more accepting of things that are more holistic and can work for that individual. Definitely kind of end up about we get the best alcohol treatment. Well, it's almost like we're doing that in a grander scheme. What works best? If sleep gets you in the door,